So today I would like to give you an update of the 20 years of research that we have been doing to develop Glyaderm. I'm a plastic surgeon. My name is Alí Pirayes. I'm a plastic surgeon in the Netherlands and in Switzerland. And I'm also the president of the Netherlands Society of Aesthetic Plastic Surgery. I also teach at the University Hospital in London. So this is a big burn conference, so I will not go very deeply into the treatment of burns, but we all know that deep dermal burns and full thickness skin defects, the absence of sufficient dermis leads to unfavorable quality especially when joints are involved, contractures are feared sequelae, and that's why the burn surgeons use dermal substitutes or dermal regeneration templates to replace the dermis and to give some kind of a guiding structure for infiltrating cells, mostly fibroblasts, to have deposit collagen according to the pattern of the matrix. So then there is a normal collagen and elastin formation apparent. Now, the dermal regeneration matrices, which have been allowed now, are really well established in acute burn surgery and burn reconstructions, but also for some other indications. But they also have some disadvantages that include the need for a two-stage procedure, the increased infection and risk, and the high cost. And since a long time, I've been involved in research of dermal substitutes, and we have developed Glyaderm. And now finally, this will be the subject of my PhD defense on the 13th of September 2023, so this year. And this brings us to the studied dermal matrix Glyaderm. It's short for glycerolized acellular dermis and is a dermal substitute derived from human donor skin. The antigenic material has been removed by using sodium hydroxide solution. The only thing that it remains are the elastin and the collagen fibers in their native spatial 3D network orientation. One of the dermal substitutes that we can use to restore is Glyaderm because it's has the human donor skin, contains both elastin and collagen fibers, and resembles the original structure of the skin. After eliminating the antigenic components, the 3D collagen and elastin fiber network remains intact. And because of the very dense fiber in the wounds, it stays longer than the commercially available substitutes such as Integra and Matriderm. This is very important because Glyaderm guides the newly formed collagen fibers to form the correct fiber pattern and not a scar pattern of collagen. The elastin fibers that are present in the dermal substitute guide the ingrowth of newly formed blood vessels. This is a very busy slide, but I want to share with you what we've been doing within the last 20 years. So in 2001, our research group formed. Then we did animal studies and favorable results of Glyaderm compared with different dermal substitutes in a pig model. These were all published in favorable journals. The first clinical case was in 2005, the first publication in 2008. Then we did animal studies to show that Glyaderm is strong for the fascia, abdominal wall fascia. And then because we wanted to help and the dermal substitutes available like Integra and Matriderm and Alloderm were very expensive, and you could not really use it for burns. And we wanted to help the burn patients. We didn't want, it's not aesthetic surgery or aesthetic plastic surgery. We really want to help. So we gave the patent away so the product would not be commercialized. And the first patients that we did were not very easy, but we also did a case of breast reconstruction, which I will show later. And we published our 1 and 2 stage procedure with 55 patients in 2014, which was interestingly also the first year that I came to Colombia and was introduced to the horrible acid attacks that happen here. And your plastic surgeons have a lot of experience with that. And we treated Natalia with the Glyaderm, which Dr. Gaviria did a wonderful job together with his colleagues. And in 2015, we also published in Nature that the collagen and elastin is long-standing. The full face reconstructions were done by Colombian plastic surgeons and myself in 2015. It's also been a product that can be used for exposed bone. Dr. Linda Guerrero, together with the Skin Bank, she did so much work and she did all her studies. And the first Glyaderm, which was produced, the Colombian Glyaderm outside of the Netherlands, is due to her fantastic work. And now we've been using it with regenerative cells from fat, with stem cells, and finally the subject which I will talk to you about in more detail, the large randomized control study which we did. So elastin sub fibers are so important because they support nerve ingrowth of blood vessels, and infiltrations of blood vessels. And what did we find out with our clinical study, and where do we stand now with Glyaderm? And this paper was published in 2015. And in this study, Glyaderm was done in a two-step procedure, and it can and showed to be used as a dermal substitute in reconstruction of full thickness burns and other skin defects. In this two-step procedure, we applied Glyaderm after ingrowth of breast vessels. Then we closed it with the split skin graft 1 week later. The results of this two-step procedure were published then in 2015. The results were very favorable, but in this time of budget restriction, the two-step procedure is not ultimately desired. A one-step procedure with simultaneous application of the dermal substitute and the split thickness skin graft, that is essentially what we would like to have in our acumen. So it's very important to know that this product is something that is should be widely used. So it also has to be very practical. Now, the study that I want to discuss in this second part of my talk is the study which has now been published in Burn and Trauma, a single stage application of Glyaderm. So what did we do? We did a monocenter study, single-blinded RCT with inter-individual comparison of Glyaderm. The primary objectives were wound healing, graft day, graft survival, and the secondary objectives were scar quality and quality of life. And we investigated this with the standard of care today. Patient characteristics showed us 82 wound comparisons in 66 patients, and they were burn injuries, they were full thickness defects after free flap removal, and also other full thickness skin defects. So a typical case is a patient admitted with a scald. The burn depth assessment is done with LDI on the day 3 of post-burn, and the LDI blue color indicates that there is a full thickness to deep dermal burn. 4 days after the allograft application, we can see that we have a granulating wound after removal, after allografts, and prior to the application of Glyaderm and after autografting. You can see later on is that this is wound bed preparation with glycerolized allografts. So application and fixation of Glyaderm on the most proximal half of the upper leg, control and intervention sites are separated by a black line, and the arrow indicates Glyaderm, which can be seen as a thin glistening layer. The autograft application and coverage is done with Surfasoft, and there is then the removal of the Surfasoft at day 6. Then there's complete wound closure 3 weeks post autografting. Then we look at the same wound at 3 and 6 and 9 and at 12 months. And then you can see that the side receiving the Glyaderm is more supple, has less contracture, and the color is more normalized compared with the other side. So what did we see? We see that most things were comparable on both sides. So Glyaderm on one side, together with split skin graft, normal split skin graft on the other side. Pain scores were more or less the same. Take rates were great. Average wound closure time was more or less the same. There were no major infections, no increased bacterial load, no loss of the substitute of the overlying grafts, and there were no differences in the objective score assessments that we did, but the opinion of the patient in this 1 year period is that the Glyaderm side was strongly significant better, not in our eyes of the blinded observers, but in the patient. And that is the single most important thing that we wanted to show, significantly improval. The biopsies showed that there is donor elastin in all but one biopsy. The high quality of elastin in the majority of the biopsies. There is a native elastin pattern which is preserved, high longevity of the fibers there. So in conclusion, what could we state? We could state that immediate simultaneous application of Glyaderm is feasible and very well done after proper wound bed preparation. You're replacing like with like. There's nearly perfect graft take, low susceptibility to infection. We didn't have loss of the Glyaderm in these ideal circumstances, I may admit, and the patients reported it to be significantly better. The cost compared to the other dermal regeneration matrices is much lower, and we are also working to see if that can be more available for like facial attacks through foundations, and I will get to that in a little bit. But the most important thing is that 1 year follow-up is not long enough, and we see in the longer follow-ups that the Glyaderm treated group really then differentiates itself from the non-Glyaderm treated group. So this is a picture of course, as you know, fantastic results by Dr. Glyaderm, and I'm so privileged that Natalia let us use this for a book that we used first time I came to Colombia in 2014 and 15, and we had fantastic results. And these results are also replicated by your team. This is the scope of Glyaderm paper, which we're going to submit with anticipation that Dr. Linda Guerrero has treated in Bogota with improved and stable range of movement at the elbow joint, superb results. And the scope of Glyaderm is not only in burns. Here we can see a 50-year-old woman with primary breast cancer before and after. So she had a postoperative reconstruction with a total implant coverage of Glyaderm. So the implant, the tissue expander with Glyaderm was applied. And then when the tissue expander was removed for the definitive implant, we saw a total ingrowth of this dermal regeneration matrix, which gave her such a stable coverage, and especially after irradiation, that is very important. Another scope is a giant hairy nevus, and you see a fantastic follow-up after 6 years. And this really shows also the pliability of Glyaderm. This lady had, unfortunately, she fell after an epileptic attack against the radiator, had a full thickness burn, and I did this operation back in 2005. And 6-10 years later is very, very smooth, pliable skin with no scarring, no neck contracture, and she's very, very happy with that. So it's been my pleasure and so wonderful to collaborate with great Colombian surgeons, and hopefully I will be back. Unfortunately, I couldn't be with you today as I'm traveling to Paris, but hopefully I will be back in Bogota and Medellin in October, and we can again work together and learn from each other. I'm fortunate that my spouse, my wife, has also been working, and she has erected this Two Faces Foundation. We invited Natalia, who's kindly our ambassador, and we want to raise funds for acid attacks, facial acid attacks, especially in Colombia and also in India and Pakistan, in places where victims need this a lot. So I thank you for your attention, and you can always contact me through Instagram or through Linda, and it was a pleasure to be able to share my work with you. Thank you so much. Muchas gracias.